before his next meeting. We're really honored to have you join us, Lawrence. This is the University of Ottawa Global Health Lunchtime Network Series, and I gave it last May around FM Vax, and I think we'll be giving a few updates on that project. But in general, I wanted to introduce myself and then give an Indigenous affirmation and then introduce you. I'm a professor at the University of Ottawa in the Department of Family Medicine, and we have a few members from the department here. I'm also the director of the Besser Center for Global Family Medicine at the college, and it's been a real pleasure working with you around integrated health systems, interdisciplinary care, mental health integration, and making progress on those fronts. These are areas in the global arena that we're mentioning next week at the World Health Assembly on Monday, and then forum in Mexico on primary health care on Thursday. And these are priorities that the various departments at the University of Ottawa really share as well. Manisha and her team are very strong on interdisciplinary approaches, as I mentioned. Claire Liddy and the Department of Family Medicine is very interested in integrated health systems. And there's a real strength since the last deanship around mental health integration as well, and some collaborations with the WHO and Lyon in France. So with that said, I also wanted to take some moments to give an Indigenous affirmation. Let me start with some personal remarks. We are increasingly hearing about the 4 Cs. COVID-19 might be officially less of a problem as a pandemic, but it continues to have effects on communities around the world. So that's the first C. Cost of living is a real issue. Conflict is a global issue, unfortunately, increasingly so. And of course, climate change. We're seeing some of that this week in Canada. And these 4 Cs are all interconnected. And I think Indigenous peoples had a real way of seeing the big picture and of seeing that everything is connected. This, in fact, is the new motto of the National Gallery of Canada, where my wife works. Everything is connected. And so we pay respect, therefore, to the Algonquin people for such knowledge. And these are the traditional guardians of this land. We acknowledge their longstanding relationship with this territory, which remains unceded. And I know you've spent some time in Ottawa as well, Lawrence. We pay respects to all Indigenous peoples in this region from all nations across Canada who call Ottawa home, and from communities around Canada. We acknowledge the traditional knowledge keepers, both young and old, and we honor their courageous leaders, past, present, and future. A few words about the Global Health Learning Network. It's a platform for knowledge growth and exchange with the goal of building a community of practice in global health that extends beyond Ottawa and that reaches researchers, practitioners, and learners from all global health domains. As part of this learning network and this monthly webinar series, it's a collaboration between the School of Epidemiology and Public Health, the Briere Research Institute, the WHO Collaborating Center for Knowledge Translation and Health Technology Assessment. We have Jen in the audience, and very, very privileged to have that center amongst the U of Ottawa network. Health Technology Assessment and Health Equity, and the International and Global Health Office, IGHO, which Manisha leads. So on to our guest of honor. We're very pleased to have you with us, Dr. Lowe. Dr. Lawrence Lowe completed his undergraduate training in medical school at Western University and his residency at the University of Toronto, during which time he also earned a Master's of Public Health with Johns Hopkins. Prior to becoming the Executive Director and CEO of the CFPC in September 2022, Dr. Lowe was the Medical Officer of Health for the region of Peel, and many of us remember his interventions from that time. He was best known for leading the Peel Public Health team through the COVID-19 pandemic. After he assumed the role in March 2020, Dr. Lowe and the team directed measures to save lives and mitigate the impact of COVID-19, while also working closely with family doctors and other partners in Peel community to deliver the largest vaccination rollout in Canadian history. And we'll be very curious to hear more about how you did that in an integrated way. Currently, Dr. Lowe is also adjunct professor at the Dalai Lama School of Public Health at the U of T and a clinical lecturer at the Department of Family and Community Medicine at Queen's University in Kingston. His teaching and research foci have spanned the fields of global health development, global health ethics, and medical and public health education, as we'll hear. And Lawrence, you would fit right into Ottawa. You've spent some time here already, and you were telling me some haunts I need to check out. Dr. Lowe is an avid runner and enjoys spending time with family and friends, traveling, playing the piano, and writing. He currently lives in Toronto with his wife, who's a practicing family physician, and his 2 young daughters. Welcome, Lawrence, and thank you very much.
Thank you so much for that introduction, David, and for the warm welcome. It's a pleasure to be with you all today. I'm going to share my screen so that we can start from the presentation that I have here. And I'm just going to see, oops, my mouse is freezing. So I'm just checking to see if that presentation has come up the way it ought to. Yeah. All right, fantastic. So, no, thank you again. Thank you, David, as well, for your own leadership and the work that you do with the Bessemer Center and at U of O and in the global health space. Certainly continues to be inspiring for myself as someone who has always been a bit of a global health keener, but really grateful for the opportunity to be here with all of you today to share some pandemic reflections. So you've heard the overly significant bio that David just read. I call it overly significant because I think it overstates the facts, frankly. But what I think I would share are two little pieces that I would share, especially for those of you who may be early on in your career and trying to launch or develop your interests in the global health arena. The first thing that I'll share is, if you're early on in your career, I would encourage you to basically try to do as much as you can in the areas that you're interested in or areas adjacent to really build up a track record, because you never know where that's going to take you. My work previously in respect of the ethics of short-term volunteer experiences and voluntourism was entirely by accident and really provided a rich experience, which I then was able to translate into reflections on equity and diversity, and also reflections on the ethics of essentially providing short-term band-aid experiences as it pertains to global health. But I often reflect that in 2016, I actually decided to curtail my formal involvement in the global health space in favor of really focusing on my public health career here in Canada. And so when COVID-19 showed up, I often joke that I may have left global health, but global health came and found me to a large degree. The other thing that I would share, and this is the other part of the bio that you didn't hear, is that I actually became Medical Officer of Health for the Region of Peel on March 14th, 2020. Which, as you know, was a great time to become a public health officer. And I think many of the lessons that I'm hoping to share that came out of my pandemic work together with my leadership team in Peel are also lessons that have applicability to many of the wicked global health problems that we face today. And I'm hoping that will also be food for thought for you as we go through this short presentation. And I've left, hopefully, a lot of time for us to sort of answer some questions and have a bit of a discussion at the end. So I neglected to put a conflict of interest slide in here. I don't have any other conflicts of interest to declare other than the fact that I'm employed by a national standard setting college, the CFPC. But by the end of this talk, I'm going to basically share a little bit about how pandemic outcomes reinforce the importance of context in interpreting data and in respect of decision making. So basically the outcomes should be interpreted in context is what I'm saying. In respect of decision,
Did we lose Lawrence, or is that me?
No, I don't hear him either, so we may have lost connection.
Lawrence, you can't hear us, can you?
This will tie this up by having a discussion around lessons learned for future emergency responses. I'm getting here that it says that my internet connection is unstable. I'm just checking, David. You look a little perplexed, and I want to make sure that everything is still good.
We lost you for just a minute, but right after you mentioned context, so we were all reflecting on that.
Awesome. All right. I will apologize. I'm at the College of Family Physicians of Canada's headquarters right now, so the internet is meant to be good, but if it's not, I'll definitely look for an alternative means. So I think first things first is really setting the context and really wanting to describe, this is the sort of question now that we're 3 years into the pandemic, now that we're out of the emergency phase of the pandemic as identified by the WHO, and now that we are sort of really, moving deep into this transition from the acute phase of the pandemic that we saw until now, one of the questions that we are all now trying to answer is, well, how did we do, right? How do we think we did in Canada? And I think, there are lots of things that, lots of decisions and things that occurred that we can look back on and say, yeah, those were right choices. Those were good things to look at. I think there were other things that we can look back and say, maybe there were chances for improvements. Maybe there were things that we could do differently. But I think the numbers really do speak for themselves. I think we were out of a study of mortality around COVID-19. Out of 103 countries, we were one of the lowest in respect to mortality rate. And out of the OECD nations, save and except for Japan, which had the opportunity to use a fortress strategy, we actually had one of the lowest impacts in respect of COVID-19 on our hospital and healthcare system. A lot of folks will actually point to the disruption and the challenges that we had with a lot of the closures and curtailments that occurred. But I'll talk a little bit about that and why that was necessary in our specific situation here in Canada. We do know, of course, that there were impacts that resulted from indirect impacts from the pandemic that resulted from the measures that were taken to contain them, economic and otherwise, but that those have largely resolved. And I think the current inflation and the challenges that we're seeing with the economic system keeping pace with demand really reflect the fact that many of those impacts were temporary. So in regards of some of the big things in respect to COVID mortality, morbidity, I think we actually got much of that really right. And especially in considering some of the indirect impacts, 2 comments. First of all, we know that things such as the backlog of surgery that we're dealing with, the mental health impacts, etc. Not surprisingly, countries that did not actually take measures to curtail COVID also saw the same. Both, where their healthcare systems were overwhelmed with COVID demand, they too had to cancel treatments and surgeries, etc. And not surprisingly, in a situation where widespread, unfettered viral transmission resulted in significant losses for communities, that also had significant impacts on mental health, well-being, child health, etc. So on balance, I think we in Canada did fairly well in trying to both thread this needle between reducing and preventing the impacts of the acute emergency from the COVID virus, but also in terms of trying to mitigate the consequent indirect impacts of the pandemic emergency on our population. But I start there because I want to say, we overall, there are definitely countries that had that may have had lower mortality rates. There are countries that had, lower impacts to their various determinants of health. But it needs to be viewed in the important piece about context. And so as it pertains to any sort of assessment or interpretation, whether it's about COVID or any other sort of global health phenomena, context matters. What you're seeing here is a photo of the Detroit-Windsor Tunnel. This is on the Detroit end. After the border was closed, shortly after the mutual border closure in March 2020. And a lot of people will often point to the success of many other countries, at least in the early phases of the pandemic, in limiting mortality and morbidity. But again, in this situation, context matters. So one country that I often hear about, that people often tend to compare our response to with, are New Zealand and Australia. These are fairly large countries that are that have similar political systems, etc. But of course, when you actually account for the context, you can understand why they may have had certain advantages that we didn't necessarily have in the beginning of the pandemic response. And I put the Detroit-Windsor Tunnel here is simply because I want to highlight one of the biggest challenges that we had in context here in Canada with our context is that we were deeply integrated with the challenged response in the United States in a way that no other country on earth was. It may be interesting for people to know that while New Zealand may have appeared to do very well in the early phases of the pandemic, in a month, they receive approximately 500,000 international travelers, which is the number of travelers that cross the United States and Canada border in a day. So the reality is when you're looking at something along the context, especially in the early phases of seeding, the silent transmission that was occurring in the United States because of their lack of widespread community testing, it's no surprise that Canada faced a vastly different challenges. And I actually think that when you view it in that context of, not only did we do fairly well on the various measures and metrics there, when you add the added layer of context that we still had to leave our borders open to traffic for trades and essential goods, which is why the region that I served, the region of Peel, became the hardest hit region in Canada, because we were still open. We were still receiving all those goods from the United States and then distributing it across the country. When you consider that our border we were never able to fully close our border, when you consider that the context of the US response was extremely challenged given the cultural and social traditions and history of that nation, when you consider just the sheer volume of traffic that led to the initial seeding in our country, the how did we do question becomes a little bit more clear in respect of where it goes. And I say that because when you look at many other wicked global health problems, whether you're looking at the mental health, the issue with, say, mental health promotion and promoting wellness in different settings, or if you're looking at things like diabetes, the context matters, the cultural context matters, the trade context matters, the economic context matters. And then what you end up having to decide and do, and what successes, what advantages and disadvantages you may have to actually address that, become manifold different, maybe from a different context that you might actually be operating in. So that's the first thing that I wanted to impress upon in my first discussion, is the idea that with any global health problem, whether it's COVID or otherwise, it's always important to consider context, because that determines how you interpret the data and
Lawrence, we just lost the audio a little bit, unless it's just on my machine. If there's a microphone,
you know what I'm going to do?
There, that's much better.
I'm going to give this a try, and I apologize if folks have been having.
No, we just lost it in the last few seconds.
All righty, let's try that.
Thank you. Yeah, excellent.
Awesome. All right, so thank you, everyone. So that's the first part. I really wanted to talk about context, and context that applies also in Canada. But you heard me talk about the story of what I saw in the region of Peel and what we were contending with. Again, a community that was essentially receiving all the essential goods, continuing to distribute them across the country. In essence, like I formerly used to say when in my public appearances, a community that still went to work in person so that everyone else could stay home and stay safe through the pandemic. That brings me to the other reflection that I wanted to share from a global health perspective, and this really concerns around the right decisions at the right time. As with many other global health problems, nothing stood still during the COVID pandemic. You were really faced with many difficult decisions, and you had to take the best decision that you could for the moment that you were meeting. I think we know, for example, that there were situations or questions around masking in the early phases of the pandemic. There were questions around testing. There were questions around was there asymptomatic spread, or how does this thing spread, or where does it spread, and who's at risk, and all these other things. But I think it's important to highlight that there were oftentimes a wide spectrum of ideas and recommendations around how we should have proceeded at any given point. And these all ranged from, COVID is overblown, just let it rip, who cares, right? To, this is absolutely the worst thing that's ever happened, and we need to absolutely close down every aspect of our society in order to get to zero before we actually move forward. And just like a multiple choice quiz, I would postulate that the answer is often not necessarily at the extremes. So, when you're working through a multiple choice exam and you're trying to figure out what the right answer is, and you're not 100% sure, usually eliminating the extremes is a good bet to start with. That our response necessarily took different decisions at different times. So in the first few waves, where we didn't have any treatments or prophylactics, and where we had a largely susceptible population that had not been exposed to the novel virus, we really needed to reduce spread, because spread was intrinsically tied to severity, right? And we saw this in other countries that didn't get this right, where they basically decided to just power their way through it, that increasing spread led to increasing hospitalizations, which led to increasing mortality. But the interesting thing that I found was, so insofar even today, as we're navigating our transition out of the emergency phase of the pandemic, is that over time the virus itself evolved, and also our population susceptibility changed. At one point, we started to have a virus that was maybe more transmissible, but slightly less virulent, and a population that had been either infected or double vaccinated or both. And so in those situations, the calculus changes, and the right decision and the balance of all the potential harms and issues that might actually be identified actually change, right? In terms of the calculus of the decision. So that's why, for example, in the first few waves, a lot of us who were in pandemic leadership understood that we really needed to. It was almost like that last scene in Shang-Chi, where they're basically trying to keep the evil spirits or whatever from bursting out of the what looked like a giant sewer grate. Like, that was essentially what we were trying to do. I think the easiest way to say this is, when you have something that comes out, when we started to identify animal reservoirs, when we started to identify asymptomatic transmission, we started to identify that this thing was spreading in no way than any other novel virus that we'd seen before, particularly airborne in certain circumstances. That was where we actually needed to say, okay, this is serious. And we actually, without a treatment or prophylactic to reduce the impacts on our society, we need to actually take the efforts to actually reduce contacts. But of course, that calculus changes once you're dealing with a different variant, and you're also dealing with differential population susceptibility as a result of infection or immunization. This also ties into not just, in terms of the overarching population health decisions, but to what David was talking about in respect of the vaccination rollout, and the role especially about primary care and public health, at least in my jurisdiction, where things were at. And how that partnership evolved. One thing that I found very interesting was that David had shared with me a slide that showed that in terms of the vaccine rollout, Canada was a country that was kind of middling in terms of the integration between primary care and public health. I think that actually really speaks to just the state of affairs between public health and primary care as it stands right now in many jurisdictions. One of the challenges I can share as a public health officer in my community was that the way we're organized here in Ontario is that there isn't really an overarching family medicine or primary care governance structure, right? You have all these little clinics. And in our case, in our community, we had 1,500 or 1,600 different clinics. But in terms of overall leadership, you could work, with Ontario Health or, the former local health integration network partners that actually were primary care leads. But ultimately, they weren't the people that were directly in charge of these clinics. They were the ones that were trying to pull together and coordinate. But clinics ultimately were their own islands, right? They were essentially small businesses that were run by the various individuals who were running them. And so that made it very challenging to mobilize primary care and family medicine in the early parts of the vaccination rollout, where time was of the essence. And so the reason why certain decisions were taken, especially in the early phase, to focus on developing mass immunization clinics was because we recognized that there was a significant amount of the population, based on sentiment tracking, there was a significant amount of the population that wanted to get vaccinated as quickly as possible, and they just wanted an easy, accessible way to do that. And the fastest and quickest way to do that was to set up these mass clinics. That's not to discount the very important role that family medicine and primary care have in really reaching especially those people that their patients trust as trusted voices, and also in reaching communities that are marginalized or potentially harmed by barriers to actually accessing this care. But what we understood was that we were essentially running two races. We were running a sprint with the vast majority of the well and able and willing population who wanted to access this protection quickly, to be able to access it quickly through mass sites. And so we went ahead, making sure that that was up and running as quickly as possible so that it could actually bring down the population susceptibility in our community. while we also worked to actually set up the agreements and the coordination and all that other stuff to bring family doctors as well as mobile clinics online for really what we called that longer marathon to reach the harder to reach, the more marginalized populations in our community. And so again, it's about the right decisions at the right time, because if you really were trying to say, in our case in Peel, we had almost 1,600 different family doctors clinics. If we said everyone go to your family doctor, that would have been an enormous burden to place upon our family medicine community, and it would have been a logistical nightmare trying to distribute to, say, hundreds and hundreds of clinics, as opposed to really making sure that you got it into the a number of centralized clinic sites that could really get people the protection they needed in a rapid manner in the early parts of the campaign. And then of course that was why then that of course left the longer work of coordinating with primary care to reach the hard to reach populations as the right decision that continued through the work of the initial phases and into the end. So, and into the end, what we call the last mile. So in essence, this is what I talk about when I talk about making the right decisions at the right time. It's important, of course, to understand context, as I've described. And then once you have an understanding of context and the actions that you take, you need to also consider, at what phase are you in this situation? Is this a mature emergency? Is this a longstanding chronic health issue? Whatever the issue is that you're working in global health, that will also help you understand, especially if you understand the other players and how they all fit into a specific situation. It'll allow you to come to make what are the right decisions at the right time for the right context that you might be operating in. And that brings me to the last point, the last reflection that I wanted to share, and then I'm happy to spend a little bit more time talking about questions, which was, we did live in a bit of a perpetual motion machine. I think this is probably the first pandemic in history where you had easy access of things such as social media, as well as really the siloing of many people's information, right? I think back in the day, in the late 20th century, while many people had different opinions, everyone watched the same TV news, everyone read the same newspapers. So there was a little bit of a sort of a flattening effect, at least in respect of the facts and what people understood as coming out as being true. But I think we all know, and we've seen this not only with COVID, but also with all sorts of other issues. I have to say the one thing that I found most galling has been the uprise and the conspiracy theories around 15-minute cities, which I think many of you may be familiar. So 15-minute cities are this concept that we should be building built environments that allow people to access their basic needs and essentials within a 15-minute walk of their house. So going to a clinic, going to grocery, going to the bank, whatever the case might be. That has been co-opted by certain groups and segments to mean that they're trying to limit and restrict movement of individuals to within 15 minutes of their house, which obviously is not the intent. It's really about trying to save people time and make their lives easier. And I'll also share, just for interest and for those of you who are in your career, who are developing your career, you may have your areas of interest, but never ignore the areas that are really salient to your overall work as well. So I was ironically never a communicable disease guy. I actually used to be a big chronic disease guy. My focus was really on the built environment and health. And so I find it really hilarious that I ended up becoming the face of COVID in the region of Peel. But that subsequent to that my other area of interest, the built environment, and really creating, healthy mixed use communities that support modalities of transport that make our lives easier, that give you options in your day-to-day, that also became the target of conspiracy theories following the pandemic was doubly ironic for me. But I think that really speaks to the perpetual motion machine that I wanted to talk about. And one of the biggest challenges that I found in pandemic leadership and in reflecting was the idea that there really became a lot of echo chambers. There really developed a lot of different groups that almost reinforced each other's thinking and each other's beliefs. And again, going to the idea of extremes, both in respect of what should be done, as well as the interpretation of what was being done, really presented difficulties and created, I think, a significant divisiveness that to a large degree was exacerbated and driven by social media algorithms and the popular media. And I think everyone knows at length how social media works in respect of when they've made that change to, what you like is what you get kind of thing. But I think the popular media also had some play in this as well, where they would put the opinion of anyone who had an MD after their name, or anyone who even had doctor in their title, they may not even be an MD, as an opinion, almost on equal footing with those of us who are actually, in the response and actually mandated legislatively to provide the best advice that we could to our communities and to our elected leaders. And that I think really challenges things, because when you flatten things, you now have potentially people who are not privy to all the data, who are not privy to the context that is used in the decision making, and who are not privy to some of the related challenges or the related receptor views and perspectives to understand how messages are going to be received. I think a really great example that I often pointed to were people that said that we should have just closed the border, at the very beginning and just left it shut and followed a fortress protocol like Australia and New Zealand did. And in reviewing things and reflecting on things with my federal colleagues, I understand, that would have probably jeopardized a lot of our food, and essential medicines chains. I think that would have jeopardized a lot of our other essential goods chains. It would have been an even more significant impact on the Canadian economy. And not to add, and the reason why I have the former 45th President of the United States on here, a unilateral closure on the part of Canada with a mercurial American president would have not been seen nearly as favorably as the mutual closure that was actually negotiated, that allowed for essential goods and trade to continue. So I think there were a lot of things, and if you actually take a step back and look at it, for those that were actually in the decision seats that were making those difficult decisions, there's a reason why those decisions were taken. But at the same time, this perpetual motion machine of social media and popular media really challenged things by confusing the public in respect of sort of who to listen to, and B, in respect of influencing policymakers and decisions. Another example I'll use besides the border, but that was in a really real way, was during the vaccine rollout, where enough people were saying, in the face of the Omicron wave, which, by the way, was coming very quickly and we were never going to vaccinate our way out of quickly enough. But when Omicron was coming at the end of 2021, there was a significant Twitter campaign that said, open up the boosters to everybody, 18 plus. And here in Ontario, the provincial government ended up going ahead and doing that. And what that did was it suddenly meant that everyone who was 50 plus in our community was basically being pushed out of clinic chairs by people who were much younger than them and much lower risk. And at the same time, it overwhelmed our system because almost 1 million people became eligible overnight. So not only were we not able to maintain the same capacity that we were vaccinating, we were not vaccinating the right people that we needed to be vaccinating ahead of the Omicron wave. And that was a direct result of a Twitter campaign that pushed the provincial government to say, drop it from 50 to 18. So I think about these things, and I think about how, we were really trying to hold the line to a large degree with all the facts in hand, the data that we had, the understanding of the political context, the understanding of all the policies, et cetera. But social media, while it is important in giving people a voice, and particularly was important in giving voice to some of our most marginalized populations, also had the double-edged sword of driving potential policy decisions by people who maybe weren't necessarily as connected with some of the details of the response and the real trade-offs that we were navigating in actually helping, in actually resulting in some hindrance to the efforts and the decisions that were taken. So all that to say, these are the lessons that I've learned, and I'm happy to have a conversation in the last 10 minutes that we have together. But I think the first thing is that decisions really need to be driven by data and context. And I put context in there because data is one thing, but you really need to understand the context in which that data is being applied, as I've said. As long as you make a decision based on data and context, then it is, as far as I'm concerned, defensible for the future. So especially if things change, if an emergency changes, whatever global health problem you're working on, if it changes and new information comes available, as long as you made the decision based on the data and context that you had at the time, it makes it defensible and allows you to respond effectively to the critiques. It also helps to draw out the context that is faced, right? If you're not considering context, then you're basically just looking at a bunch of numbers. The other thing that I often say is it's important to really realize that there's nothing without trade-offs. So it is important to really look at focusing on the reasonable middle. You know, the media, popular and social, otherwise often pull to the extremes, and that's really how they sell news stories. But the reality is that if you're coming out with a message, and I think the old joke, the old quote that a friend used to say is, if you're getting shot at from both sides, you're probably on the right middle ground. So basically, if your message is being received poorly by the extremes, most reasonable people in the middle are probably understanding the trade-offs that you're making with the decisions that you're taking. And I think that's a really important thing for me to share. And then the last thing I'll share is that time heals all wounds and reveals all truths. I think now we're seeing that a lot of, and I still remember in the middle of the response, you know, it's important for us, especially in global health work, to avoid calling winners too soon, right? It's like, oh yeah, they did a great job. They kept COVID out, you know, and I always remember saying, yeah, it's great. They kept COVID out, but what are they going to do when the rest of the world moves on? What are they going to do with, like, they're going to need to reconnect at some point, right? You can't just stay disconnected for the rest of your life. So, you know, I think it's important to make sure you guard against hubris and you make sure that you've taken the right decisions, because not only it makes your decisions defensible in the future if they're drawn on data and context, but it also allows pushback against revisionism, especially the revisionism we're seeing nowadays, where it's like, oh yeah, it wasn't that bad. We didn't need to take those measures. We clearly knew what this was all about when it came around in March 2020. So I really want to thank you all for your time today. I'm happy to take any questions you might have, and I hope that those reflections are helpful, whether you're working on COVID or any other global health challenge you may be faced with in the future. David, I'll pass it back to you.
Thank you so much, Lawrence. What a treat to hear your analysis of a situation that's still ongoing, but a situation that you were so involved in intimately. And some of those pearls ring so true, you know, the importance of context, the importance of timing, those second and third dimensions to complete the picture of a health decision as we analyze it. And also the importance of looking outside one's own context to learn from others. I mentioned this at the outset, but often we get a bit parochial during times of crisis. You and I have talked about this before.
Oh, yes.
It's easy to look at one's own crisis as the immediate one, the only one, but it's also easy to get caught in one's own ether without looking at other solutions. And by global standards, I think we all agree Canadian healthcare is very, very, at least in primary care, is very, very devolved, as you were saying, to the practice level. Agency, a great deal of agency lies at the practice level. And so how do we standardize the sector and how do we encourage collaboration with others? So, je voudrais aussi remercier Dr. Lowe en français et on peut prendre des questions en français pour les prochaines 10 minutes. Merci beaucoup, Lawrence, de rester avec nous pour encore 10 minutes. Est-ce qu'il y a des questions parmi les membres qui ont écouté? Merci beaucoup. I'm not monitoring the chats. Let's see here.
Sorry, I see Manisha's hand.
Okay, Manisha, go ahead.
Hi, thanks so much for that talk, Lawrence. It's just really great to hear your reflections and experiences firsthand. I was really, I liked your comment about the sprint and the marathon in terms of reaching, you know, the underserved populations, and was wondering, you know, what strategies did you find that worked in terms of reaching, you know, the marginalized populations, and what strategies do we need to ensure stay in place so that we don't experience these similar types of inequities in future pandemic response, but other public health responses as well?
Absolutely, Manisha. No, thank you for that question. I would actually start by just highlighting that from an equity perspective, I don't think the pandemic necessarily worsened or created inequities. If anything, they just exacerbated and revealed them. And that is really the reason why the region appeal faced the brunt of it in the first few waves. You know, it was an international hub. Many of the people that were going were truckers, typically are immigrant truckers. They were driving to the United States, which was, as we all know, completely out of control, coming back with COVID, bringing it back to their homes and bringing it back to the warehouses where they were dropping off the goods, and then it was spreading within the warehouses. Essentially, that made Peel, similar to Laval in Montreal, or in North Montreal and also Surrey, portals of entry for that disease, while the limitations of context were there. But that was really driven by equities and disparities in the nature of work and the nature of who does that work and where they do that work. To your question around the vaccine outreach, it was so I do not take credit for this at all. I will always name him because he's the one that came up with it. His name is Brian Laundrie. His name is Brian Laundrie. He's a director at the Region Appeal with the Health Services Department. And he had this brilliant idea to create community tables for specific equity-seeking groups as part of the vaccine rollout. So we had a Black African and Caribbean table. We had a Islamic table. We had a South Asian table. We had all these different, like I think he had a whole list of 13 or 14 tables, and he and the rest of his team actually pulled them together in the very early stages of the vaccine rollout, even before we had any doses, to just say, all right, so when this vaccine shows up, how are we actually going to get out and reaching out to your community? And by listening to them, it was so important to the delivery. It was so critical to understanding the effectiveness of delivery. Now you can imagine all that stuff took time. So in the early phases of the pandemic, one of the criticisms was, oh, well, the vaccines aren't getting to the right people. But those conversations were all happening and getting set up as the mass clinics were up and running to at least, reach the populations that were willing to get vaccinated at that point in time. But by the time we actually got to it, we were holding vaccination clinics in masjids, in mandirs, in like you name it. Like it was literally everywhere. We had a Black African and Caribbean clinic that was staffed by Black African and Caribbean staff. We had a women's only clinic in a masjid. Like all these kind of things that were actually deliberately intended to make sure that people felt culturally safe and felt able to access that protection and get their questions answered in a manner that was appropriate.
Great, thanks so much.
Great. So in the last few minutes, I'll read a question from the chat and also introduce Marie-Hélène Chemienne, a colleague from the department here. Deborah asks, how do you educate and help politicians to take a data-driven approach? And Marie-Hélène had a question as well. Marie-Hélène is very instrumental in our Benin project at the University of Ottawa, and we're trying to collaborate on some of the fellowships that are coming our way from Africa, Lawrence, including from Madagascar. Marie-Hélène, vas-y, à toi.
Oui, merci, merci Lawrence, great presentation. But I came in a bit late, and I'm sorry if I missed the issue between primary care and public health, because I thought that was one of the major things where there was a disconnect between public health and primary care. We could have helped much more. We should have been there, and it seems that we weren't sort of integrated with them. And just to comment on the previous intervention by Manisha. Hi, Manisha, how are you doing? I participated in a presentation where there was Toronto, Montreal, and Ottawa who were, sharing the way they answered to the question of reaching out to those communities. And it's really a question of being very point of care, the proximity. You can't do it from afar. You can't do it for even social media. You have to be there. You have to meet them. You have to speak with them. It's really de la proximité qui est importante. And that was the commonality in the three different strategies, or the different strategies that they had used, whether it be Toronto, Montreal, or Ottawa. So as you said, having, the Black African table or the Asian table or the mainly the women's table when it's mainly due to the Islamic religion and all that. So yeah, absolutely. So, but why? How do you answer? Why were we not more there with public health?
Yeah, absolutely. So I'll start with that, and just to reiterate, I think it was about time being of the essence. And so the desire was to move quickly to provide access to as many people as were possible, without necessarily needing to deal with the logistical challenges of sending vaccine out to so many different family medicine clinics and all those other pieces. So there was a sprint to really try to vaccinate as many people as possible in the mass facilities, while the whole system of and we also recognize this as well in public health, that in the long run, it was really going to be done out of family doctors' offices in the way that flu vaccine, et cetera, were. But the time it was taking to get that system set up, while that was getting set up, that was where the mass clinics at least got started on the bulk of the population. So I think this could be alleviated. And now that I'm sitting where I am with the College of Family Physicians of Canada, we're pushing for things like team-based care. We're pushing for improved primary care coordination across the system. Right now, we really don't have a system. We have like a number of different family medicine clinics that all bill a common, insurance provider. And there is, I think, room to improve primary care coordination as it's linked to public health with some sort of governance structure to really make sure that there's an easy way to bring together all those clinics and to bring together the sector in the future. But then I guess to the other question around how to help and educate politicians to take a data-driven approach, I would actually say they do take a data-driven, they were taking a data-driven approach, but they're also beset on by a lot of other competing interests. And that actually is, because I remember we were always asked, when we were asked at provincial tables, is like, what's the data, what's it showing, et cetera. They would take it into account. But, you know, I think the nature of the art of politics is when you've got all these different competing demands, then the data, unfortunately, becomes one very small part of your decision, or it becomes a part of your decision. But really, that's where context, again, that's where data and the interpretation thereof really needs to be taken into account with context. And I'll share just for people's background, I know one thing that people got heavily debated about was the closure of the schools in Ontario and, you know, the potential harms. Leaving aside the fact that I think, you know, children who lose parents or grandparents or loved ones also experience significant mental trauma and mental health issues. One of the reasons why we actually moved to close schools in the region of Peel during the third wave when community transmission got high was because we were already closing schools left, right, and center because of all the exposures we were seeing. Our schools team was already seeing hundreds of, we already had a backlog of hundreds of exposures. And it was literally like playing whack-a-mole with COVID. You know, it was a school over here, a bunch of schools over there, some classes at that school, some classes at this school. And at those levels of community transmission, we were realizing that the exposures and the measures were just not necessarily holding, given how high the community transmission had gone. So at that point in time, we felt it was, given that schools were already closing haphazardly, we felt it was important to move to a orderly, controlled closure while we got over the crest of the wave. Now, of course, then the decision that was taken after that was to leave them closed for much longer than we had intended, right? And so that becomes that issue of the art and science of politics and how data drives it. But I hope, Marie-Hélène, that explains a little bit around the urgency as to why mass clinics started out while the family medicine coordination was being brought into place.
Yeah, for sure. At the beginning, I don't think primary care was, ready to have a, minus 70 refrigerators or all that at the beginning. It changed along the way, but no, absolutely. But still, I think we could have been more working together next time.
For sure. Good lessons, good lessons and thoughts for sure.
Excellent lessons for working together as the crisis evolves and shifts and morphs. The importance of context, the importance of timing. I recently read that excess of 10 million teenage pregnancies have occurred in sub-Saharan Africa due to school closures. So timing and context and making decisions that are best for the context are always important. Thank you so much for those reminders, Lawrence. Thank you for taking the time. I'm glad we're leaving you a little bit of time before your next meeting. And inshallah, let's try to do this again in a year and continue to exchange lessons. Manisha, did you want to close up the series for the year?
Thanks, David. Just a quick note to everybody. Thank you so much for participating in our Global Health Learning Network. Thank you so much, Dr. Lowe, for closing out our season this year. I think you've left us with some great thoughts and food for thought moving into the summer and what will hopefully be an easier time from a pandemic perspective. And we invite everybody to join us back in the fall. We'll be starting up again in September. So keep an eye out on your inbox for the Global Health Learning Network. Thanks again, everyone, for coming. And there is a poll that was put up. If you can answer a few questions for our evaluation, that would be greatly appreciated. Thanks again, David. And thanks, Dr. Lowe.
Thank you all. Have a wonderful long weekend.